Welcome everyone, and thank you for joining us for the 2025 Endometriosis WA Symposium. I'm Emily Greygoose, a board member with Endometriosis Western Australia and a PhD candidate at Curtin Medical School. I'll be guiding you through today's event. We would like to extend a special thank you to our co-host Proteomics International, a Perth-based medical technology company dedicated to developing blood-based diagnostics for chronic diseases, including endometriosis. So their mission is to improve the quality of life for people with chronic conditions by developing innovative diagnostic tools that enhance the detection and treatment. Later, you will be hearing from Dr. Kirsten Peters, Head of Clinical Studies at Proteomics International, who will be talking about their latest publication and describing the development of their blood test for endometriosis. So I would like to start this event with an acknowledgement. So we acknowledge the traditional custodians of the land we gather on today, the Whadjuk people of the Noongar Nation. We pay respects to elders past, present, and recognise their continuing connection to land, water, and community. We also extend this respect to any First Nations people in the room today. As we work to improve health outcomes for all, we may do so in the spirit of learning, partnership and respect, ensuring culturally safe and equitable care for First Nation peoples now and into the future. I would also like to recognise that presentations today may include gendered language. Please note that this is not intended to exclude, invalidate or cause any distress. At Endometriosis Western Australia, we are committed to inclusivity and recognise the diverse identities within our community. We strive to create a respectful and supportive space where all individuals feel seen, valued and included. If you have any concerns or feedback, we welcome open conversations to ensure a more inclusive environment for everyone for all future events. So please come and see me after, okay? A bit of housekeeping. So I'm going to read this off the safety brief I've got here. When needed, restroom facilities are close and just down the corridor. So if you walk out here, just past the tea tables, and the promotional posters, just down there on the left. In the unlikely event of an evacuation, building wardens will instruct us towards the emergency exits, which is out this side door here. And the meeting place is the Verdun Street in front of the neuroscience building just behind us. I'm sure the wardens will follow us, lead us and direct us out there if we do get a little bit lost. So at Endometriosis WA, our vision is to provide people affected by endometriosis, including their family and carers, with access to the best quality information, care, support and understanding. And with Proteomics International, the mission is to improve the quality of lives by the creation and application of innovative tools that enable the improved treatment of disease, with their vision to help create a world where disease is detected early and cured simply. So we've got a lot of overlapping core values, and we are excited to be sharing this event with them today. At Endometriosis Western Australia, our core priorities are in awareness and education, research and support. So we've got a number of events and social media campaigns where we are present within the community and on social media. With our research, we like to support local research projects and disseminate research findings. And we also provide consumer input on grants and research objectives. And we have an online support group that currently supports over 4,500 West Australian people with endometriosis. And additionally, we offer a free bi-monthly event and newsletter for our members. The Facebook support group is free for anyone with endometriosis. If you just need to vent, if you would just like to relate, you are more than welcome. It is a very inclusive and very supportive community. I would like to do a brief shout out to some of the things we've achieved with Endometriosis WA this year. So the University of Western Australia, in collaboration with Endometriosis Western Australia, is offering a $5,000 scholarship to support honours students dedicated to researching endometriosis. And as advised earlier and seen on our website and social media pages, we do advertise projects that are currently recruiting for participants. These are some of the more recent ones that we've updated on our website and social media pages. If you're ever interested in seeing what's currently being conducted or would like to participate, please feel free to look to these spaces and just see where we're at with our local community. Or if you have a project you would like to advertise, please reach out and we'll see what we can do. Okay, so for the agenda today, I won't hold you up too much longer. From 10 to 12, we have our guest speakers for about 15 to 20 minutes each, with 5 minutes for questions after. It is a small period of time for questions, so if we don't get a chance to get to you, please keep it in mind. And there will be networking from 12 to 1 out in the lobby with some food and drinks. Feel free to approach our guest speakers there and just ask your questions and we'll be happy to help. Okay, so I would like to now introduce our first speaker, Miss Lucy Stewart. If you'd like to come up and get ready. Of the Pelvic Pain Clinic and the Garden Medical Centre. Lucy is a current medical student and Women's Health Project Coordinator at the Pelvic Pain Clinic. She played a key role in the development and implementation of the Pelvic Pain Clinic and conducts screening telephone calls with all new Pelvic Pain Clinic patients, oversees current service provision and provides support to the wonderful health professionals at the clinic. She is thrilled to be here today and we are thrilled to have you today. Thank you so much. Let me.
Beautiful. Thank you so much for having me. I thought I would just sort of give you guys all a bit of a rundown on the clinic and what we do and why it's all very exciting, because it's a relatively new model of care in terms of managing complex chronic conditions like endometriosis. But first, I'll start with an acknowledgement of country, just acknowledging that we're meeting on Whadjuk Noongar Budja, and the First Nations people are the first healers of this country, and I think we have a lot to learn from them. And I'd just like to pay some respect to elders past, present, and emerging. So at the Pelvic Pain Clinic, we have sort of like a multi-step process in terms of what all of our patients experience. So initially you sign up to us, it's free, you don't need a referral from any doctor, you can kind of just find us online or via word of mouth or however you Google or however you end up finding us. You fill out a pretty comprehensive screening form, which takes a little while but is really useful in helping us sort of like guide the consult, and it covers a range of things including symptoms that you might be experiencing, which could be pelvic pain, bladder symptoms, bowel symptoms, back pain, sleep, headaches, a whole range of things that are often associated or present with things like endometriosis. We then have the screening phone call, which is what I do, and that's like a 45-minute block with patients, and we ask them essentially about the screening form that they've filled out. So we use that form to guide the interview sort of thing and just allow people to sort of like explain their journey and what they've been through. And we thought that that was like a really important step, because a lot of the time, a lot of patients feel a bit frustrated and that they're not being heard. So it is a pretty significant block of time with someone who knows what they're talking about and can offer some advice or maybe guidance on like where to go to next. And then there's a couple of options of what people can access after that. We get people coming to us at a pretty broad range of points in their endo journey. So some people maybe are just starting to look into why their periods are painful for the first time. And so they tend to start with a GP consult, because the GPs can be really good at just providing a little bit of education and counselling, and then sort of guiding them as to what might be the best option for them to take next. But then we get other people who've been diagnosed with endometriosis maybe 10 years ago, and they're really happy with how their GP has been managing their pain, and they just really want to access all the allied health services that we have, and that's totally fine with us as well. So they can access, we've got a pelvic health physio who's on site for us, who does a lot of work with sort of like the more, I'll leave it to Joe to explain a little bit better, but the more like musculoskeletal side of pain is how I like to describe it a little bit. And then we've got psychology services, and we've got a dietitian that we work with who's based over Eats, but she's got a huge amount of experience in female like hormonal conditions. So she does patient workshops for us. She's doing one next week. I think it's like 2 hours on an introduction on how diet can be used for the management of endo and pelvic pain and things like that, which is great. Then a little bit after you've accessed any of these services, we do like a check-in call just to make sure you're doing okay, if you're happy with the service, any options that you need us to provide, or any like if you need any clarity or anything like that. And then we have a patient discharge sort of form, which is in the form of a pelvic pain action plan. And that's just sort of gives people a little bit of direction on, the tools that they have to manage their pain, things that they can access either through us or through their own resources, and then strategies that they can use either to prevent a flare-up or to relieve a flare-up when it's happening. And it's just really nice to have a bit of like a concrete thing that you can refer to if you're feeling a bit overwhelmed or intimidated by a flare-up. And it's just kind of nice to have that toolbox to kind of let people walk away with, which is great. We've had quite a large number of patients come through us. I think it's been about 365 to January this year. To December last year. Obviously, most of the patients that we have present with pelvic pain, but they also present with a lot of other things like bowel symptoms are really common, back pain is quite common. And so it really just emphasizes that endometriosis is like a whole body condition that requires a lot of different sort of treatment options to try and manage all of the symptoms that you're experiencing. In terms of where the patients go from here, most of them get referred to or access the allied health services that we have. So that's predominantly physio, but also the psychology services that we do. Many of them get referred to a specialized imaging center so they can maybe look towards a diagnosis of endometriosis, of which specialized imaging is really, really important. And then some of them get, a medication review and a medication prescription, and some of them we send off to specialists for things like laparoscopies and things like that. So there's a pretty broad range of things that we do, but we really sort of emphasize the importance of having a toolbox of things that you can access, because there isn't a one-size-fits-all approach to managing the endometriosis symptoms. And so we really just want to improve accessibility of all of those different things so people can try and find out what works for them. We've had pretty good results so far. So these are just a couple of like questionnaire things that we get people to fill out before and after coming to us, and essentially a decrease in your score. The higher the score, the higher the impact the symptoms are having on your well-being through a number of different measures. And they're all negative so far, which is really promising to us, and obviously really exciting that we are able to provide services to patients that are effective. We've had some pretty good feedback, which you can read if you want, but I think one of the biggest things that we're finding is that patients are really appreciating the specialized clinic and having people that know about endometriosis and they're educated, and just having that all under one roof, I think, has been really beneficial to them. So what can you do to make the most of your pelvic pain GP appointment? I kind of had like 5 little bits that you could, that I would maybe recommend you try. The first one is to identify and set your priorities. So have a think about what you want out of the appointment. You need to prioritize the symptoms that are causing you the most trouble. And that's sort of a big part of what we ask about in the screening call is like, we understand that you're experiencing a lot of different things, but what's causing you the most stress? And it's really important to be able to articulate that to your healthcare professional, because, maybe for us, like pelvic pain is the biggest thing, but for a patient, having to get up and go to the bathroom every 5 minutes is the biggest disruption to their life for them. And so it's really important for us to be able to recognize that and make sure that the management options that we provide align with the priorities of the patient. Try not to make too many goals if you can. I know there can be lots of different things that you want targeted, but sometimes you do just need to take a stepwise approach of like little baby steps and like try and think of the long-term goals, because it is sort of one of those things where you have to just target one little bit at a time, maybe. The second one I would say would be Come Prepared. So there's a bunch of really amazing apps like Matilda and Quendo and Friendo that can be used to like track your symptoms and have like a bit of data in terms of your experience with pain and other symptoms. So I would say like download them if you can. And then it makes it a lot easier when you're coming into an appointment to be like, I had pain this many days last month. It was rated 8 out of 10 on this day and then 2 out of 10 on this day. And it really helps your doctor understand what you're going through. And it also makes it kind of hard to debate. The third one would be have realistic expectations, which might be a tough one to hear for some people, but unfortunately, coming into an appointment and asking just to be sent for a laparoscopy straight away or to have all of your pain cured is not realistic. We wish it was, but unfortunately it's not. So you do have to kind of, maybe have a bit of a read or go on to like a support group and figure out what everyone else is kind of going through in their appointments, and then kind of figure out what's kind of going to be the most realistic option for you. Having too many goals and things is hard, especially because we do have like limited times and appointments and stuff. My next one would be open-minded and listen to the experts. I know that sometimes some doctors can come across as like a little bit rigid and time poor, but I promise you they do really want what's best for you and they do really want to help. There are certain things that clinicians do and don't do out of necessity. And I think sometimes you just have to trust the process a little bit, but also like ask heaps of questions and ask why they're doing things the way that they are, because I'm sure they have reason for it and they'll be very happy to explain it to you. And then my last point would be, if you don't have rapport with a doctor, find someone else, but don't give up. There are some personalities just click better with some people than others, and that's totally fine. But you do just keep seeking the help that you need, and hopefully you'll find someone that you can click with and that can give you what you need. And then part of that would be, don't be afraid to advocate for yourself. That's sort of like what my next kind of thing would be talking about, which I've got here. There are a couple of, this is a table that I took from like a study which was talking about self-advocacy for rare chronic conditions, but I thought that it was like kind of relevant in this setting as well. It is really difficult and it can be exhausting and it's quite intimidating to advocate for yourself, but try and empower yourself and believe in yourself and hold true to what you need and want. And then that is how you're going to get the most out of your appointments. I know sometimes, like, as someone that's going through this like very exhausting ongoing chronic condition, you just want someone to be like, this is what you need. But sometimes that's not an option because it's your body and you know what you need. So try and find someone whose approach aligns best with yours, whether it's holistic or a multidisciplinary team, or like just aligning with the priorities that you've set for yourself. And that can be really useful. There was a study that looked into the perspectives of people living with endo, and it found that self-educating resulted in like empowerment, and then that allowed people to be equipped with the knowledge and understanding to navigate their healthcare appointments better, which then led back to further empowerment. And it's like a chicken or the egg sort of situation where it's a really, really useful cycle. You just need to kind of find a way to like break into one point of it, and then it'll just keep getting better and better, hopefully, in the end. Self-compassion is also really important. So it is important to make sure that you understand what your mental health needs are and like go a little bit easier on yourself if you feel like running into dead ends a little bit. Just take the time to be patient with yourself and be patient with your healthcare providers, and like hopefully you'll find a solution in the end. And then, yeah, so these were the domains of self-advocacy for like rare diseases. So try and educate yourself, take care of yourself physically and psychologically, make sure you find good practitioners who will have therapeutic alignment with you and what you're after. The symptom maps are really good. The emergency preparedness, which could be something like our pelvic plane action plan that I was showing before. Educate yourself and like people around you, like people that love you and care for you. Like things like this, symposiums and webinars, and there are some really good books and podcasts and things around that can be really useful. And then research and feedback is super, super important. So if you have the time to fill out a survey of someone, like a research group that's looking into endometriosis, it's completely invaluable. Like, we really need more information on that. And then if you're accessing a service and they ask for feedback, then please give it, because that's how we improve our services and tailor it best for you. And that's it from me. Do we have any questions?
I don't really have a question. It's just more of a, I have endometriosis. I was diagnosed a while before the pelvic pain clinics came forward and were available. And I would just like to let everyone know that I sort of threw myself as a guinea pig in there a little bit. I needed a new GP. I went to the clinic and I didn't tell them I was in research or that I had a background with endometriosis at all, just to see how they supported me through the GP clinic and sort of saw what services they provided. And I have never felt more heard by a GP or supported. They were the first GP clinic, and I've been to about 10, that actually asked me how I'm managing my pain and if there's anything they could do to help. Like, they recommended a physiotherapist, they recommended mental health care, and they recommended changes to my current diet as well. So I am really appreciative of everything you're doing at the clinic, and I just wanted to say thank you.
You're welcome.
Thank you. Is there any more questions at all? No? Oh, is there one over here somewhere? No? Okay, well, I'll move forward. If you would like to come up and speak about the clinic after the symposium, there will be a chance after as well. Feel free to come up to me and ask any questions you'd like as well. Thank you very much for joining us today. Thank you. Thank you. Okay, for our second speaker, I would like to introduce Miss Joanna Morris, a pelvic health physiotherapist and co-founder of Matilda Health. There we go. Oh, there she is. Specializing in endometriosis, pelvic pain, and sexual dysfunction, Jo built Matilda with Dr. Wernley to provide affordable and accessible holistic care before and after laparoscopic surgery for confirmed or suspected endometriosis. So thank you so much for being here today. Are you up here?
Yes, I'm this one.
That one? How do I do this? PDF. Do you have it in PowerPoint?
No, it still shows on the screen. We did it before. It's just I'd have put it on.
I'm going to steal Catherine quickly.
Okay.
While we wait for some technical issues, I just want to get a quick gauge of the room. Can I ask you politely to put your hand up if you're involved in research at the moment? Yeah, I see a couple of hands in here. Yeah, a couple of hands. How about if you are from a clinical setting, you're a GP, you're a physiotherapist? Anyone here? Oh, perfect. Hi, thank you for joining us. What about if you have endo, if you have a family member struggling with endo, if you're suspected of having endo, or don't feel free, you don't have to put your hand up, that's fine as well. Welcome. Welcome, everyone. I remember my first symposium, and I had lots of tears. It was very emotional. I'm a big crier, so if at any point through any of the presentations you feel a bit whelmed, if you want someone to sit with you to cry, I can cry. If you would like a private moment, feel free to just sit there and I will ignore you and pretend like I don't see you at all. If you would like a tissue, just like, okay, don't blink twice, maybe do something a bit more obvious. I can bring you over a tissue. Maybe just put your hand up and go like this. And I will do that. Oh, we're all good?
Thanks, Em.
Thank you. Welcome, thank you.
Hi, everyone. I'm Jo. I am a pelvic health physiotherapist by background, and I'm one of the co-founders of Matilda. So I'm going to talk from a physio point of view today, and I've been a pelvic health physiotherapist now for my 10th year. And I initially thought, I worked at King Edward initially and thought that I was very into pre and postnatal care, but then really, as I started treating endometriosis and pelvic pain, found that that was my real calling. The complexities of the disease and of pelvic pain and the impact you can have as a physiotherapist was had a real pull for me. And I think that Matilda, which is a program designed to optimize people's surgeries who are undergoing laparoscopic surgery for endometriosis or suspected endometriosis, is kind of evolved because of that. So it's a Sunday, so today it's a bit more of a fun presentation, and I want it to be really interactive. So ask as many questions along the way. And before I begin, I'll acknowledge as well the traditional custodians of the land. So our elders, past, present, and emerging. Matilda is an innovative company, and we always like to acknowledge the true innovators of our land and who we learn from today. So we also can't work out how to make it full screen, so we're just going to have a little border of a PDF around it. So the goal of today's presentation is for me, I want you to be able to leave here understanding how physiotherapy supports a whole person recovery. So I'm not sure how many people have seen Inside Out, but it's played a lot in our household. So Inside Out shows lots of different emotions and how it really represents a whole person. And I think we need to think of treating endometriosis like that too, that really there are so many facets, and Lucy talked about that, there's so many facets that need to be supported, that we can't just say, we can't say, you go to your GP or you go to your gynecologist and that's it. That's not enough. There's so many facets and it presents differently in every person. So I like to think that, and I always laugh when I watch Inside Out because it's all different emotions and everyone's are different, but realistically, that's how everyone's endometriosis presents differently, and we should treat everyone like that. So this picture, for all my Taylor Swift fans in the audience, is a representation of Taylor Swift's love life, which is complex. So as is endometriosis. So I'm a big Taylor Swift fan. And I hope that a lot of other people are in the room. So endometriosis is a whole body disease, and I'm not going to explain it because I'm sure everyone else is going to explain it today, but it's a whole body disease. And so it's not a reproductive disease. It's not a gynecological disease. It's a whole body disease impacting multiple systems. And it can impact with pain, bladder and bowel function, pain with sex, posture, sleep, mental well-being. And so the role really is to look at all these different facets and see who can interject. I'm going to talk a little bit about central sensitization because that's something I think as a physio we play a really key role in. So how it impacts your nervous system. And normally I like to draw a little picture with this, but essentially if you imagine that someone starts getting pain at 13 and their pelvis, I always think of it like the Nurofen packet, their pelvis lights up. So the brain thinks of the pelvis lighting up. The information goes up to the brain. The brain is the little data center that takes all the information and says, what am I going to do with this? And it says, what you're feeling is pain. But imagine that happens every single month, every single 2 weeks, multiple times a month. We can't expect the brain and the nervous system not to make changes. That's how we adapt. That's how we survive. If you walked out of a cave every day and you saw a tiger, you'd start to think there's going to be a tiger every time you walk out of the cave. So our nervous system will adapt. And what we need to highlight with people with endometriosis or pelvic pain is that that's something that needs to be included within treatment. That if we, as physios, I'm going to talk about pelvic floor muscles, all good physios talk about the pelvic floor, but if we just treated the pelvic floor but didn't treat the driver behind what was causing tension in those pelvic floor, which can be things like an upregulated nervous system, then we're not going to optimize the pelvic floor long term. So we really need to treat the whole body, including the nervous system. So things that upregulate a nervous system, so poor sleep, poor mental well-being, fear, so fear of pain, fear of not having a treatment plan. So Lucy had a really good outcome, one of my favorite outcome measures up on her slide, which was pain catastrophizing. So that fear of what if I'm not better in a year? What does this mean? So looking at that, all of those elements, and actually if we educate people on pain and pain science and easing their fears, can we actually improve them in a year's time? So that's my little tidbit on central sensitization for this slide. and the importance of holistic care management and long-term holistic care management. So in your care team, and I debated heavily whether there would be a Spice Girl picture on here or a Taylor Swift picture, but in your care team, there should be a gynaecologist, a GP, a physio, a dietitian, all of these people, which doesn't sound affordable, I can appreciate that, but being able to access them through the clinic or being able to access them through care plans from your GP and little bits at a time. So you have that whole care team, like if you were someone that had diabetes or asthma, because it is a chronic disease, like other chronic diseases. So my key takeaway from this long-winded Taylor Swift slide is that pain is real and complex. Endometriosis is complex, and therefore the management should take that into account. So is it going to come? Let me see here. What is the role of physiotherapy? So physiotherapists, everyone's biggest cheerleader. So we are here to optimize your whole body. So let's talk about pelvic floor therapy first. So, and I'm going to talk you through how we assess the pelvic floor, what the pelvic floor are, and why they're so important. So the pelvic floor are a sling of muscles that extend from your pubic bone at the front to your tailbone at the back. And they sit like a little bowl, and you imagine that your bladder exit, your vagina, and your bowel exit come through them. So if everyone kind of makes this shape, you can imagine then it squeezes shut when you don't want to empty, and it relaxes when you do. Okay, so you've got kind of tension and relaxation. Just like your bicep, it tenses and it relaxes. The pelvic floor have a role in maintaining our continence, our sexual function. They support with our tummy, our back. They have a role in maintaining abdominal pressure and holding everything in place. So they're the bottom of kind of our abdominal circuit. Okay, so through that true core support. The problem with pelvic floor muscles that if you imagine a bird hurts its wing, it will hold its wing close in a tense position to protect it. If you have a pelvis that is experiencing pain, your pelvic floor will tense up to protect it. And so what we commonly see in people with pelvic pain or endometriosis is pelvic floor tension and the inability to relax their muscles. All the pelvic floor videos on TikTok, anywhere on social media, everyone talks about the pelvic floor trend at the moment where you're doing your pelvic floor to different songs and things like that. They're all about strengthening. So the problem is that people pick up a pamphlet, and what we talk about in the world a lot is pelvic floor, weak pelvic floor. Everyone talks about leaking, things like that. But actually, tense pelvic floor in this population are a much bigger problem and really have quite similar symptoms in some ways. So people can leak if they have tense pelvic floor. They can have pelvic pain. Lots of people will describe an inability or pain to have penetrative sex. They'll have problems emptying their bowels. They'll have a dull ache. And some of that can be muscle related and not related to your endometriosis. So people with pelvic pain and no endometriosis can have tight pelvic floor too. How do we assess pelvic floor? So there's a couple of different ways. One way is in a physio appointment, so we allow 60 minutes for an initial consult, is that we ask you a huge amount of questions. And I mean, sometimes the full 60 minutes of questions about what your life is like and what symptoms you're experiencing day to day, trying to work out, are some of them related to muscles that we can optimize? So they might be things like, do you experience constipation? Do you find it difficult to do a wee? So I always think about the first time I had a young girl come in when I was working at Pelvic Health in Subi, and she came in, she said, I feel like I sit on the toilet for ages at school and I can hear everyone else weeing, but I can't start. So she had that hesitancy to start. And that can be a symptom of it being difficult to let go of her pelvic floor muscles. So, or the stop-start wee or a slow trickle. So things like that you think, I would have never thought that was part of those symptoms, can actually be a pelvic floor dysfunction. Your more classic examples are pelvic pain and pain with sex. So people that say, I try to have sex and it just doesn't go in, okay? That can be a pelvic floor dysfunction. How do we then assess it? Two ways. So we use a real-time ultrasound machine, which can sit on your belly, and that looks at the rise and fall of your bladder. That tells us a little bit about how much it moves. It doesn't tell us if it's tense or not. It just gives us a bit of an idea, and it's a really great non-invasive tool. So we use that a lot as kind of a first entryway, I suppose, into assessment. And the second way is more invasive. So we, pelvic health physios who are trained to do vaginal exams, what we're looking for is a bit different to what your GP or a gynaecologist might look for, but we're looking for mapping these muscles. So I think of it as, if you've got a whole sling of muscles, my job is to work out which of those muscles is working well. So some of them might be working well. It doesn't mean that they're all tight, because there's lots of little ones in there. And which ones are causing problems. So which ones are painful or aren't able to relax well. And then be able to teach you how to do that. So specific to your pelvic floor. So for example, you might find that people have more bowel symptoms of endometriosis. The bowel muscles related in their pelvic floor are more tight or painful. And it's about treating those muscles specifically, and their bladder muscles might be fine. So it gives us a really clear understanding of what's going on, but it is more invasive. So that's something that often we coach up to. We talk a lot about movement. So I have a rule when I treat that all movement any sort of movement counts as exercise. I'm not going to tell you ever to do any exercise that you don't want to do, because no one will stick to that. I would be happy, I would say movement counts as walking around your house. Movement counts as deep breathing exercises. Movement counts if you walk around your office at work. You never fear that a physio is going to tell you that you have to go to the gym. Absolutely not. Or that you have to do any sort of formal exercise, because that might not be for you. But there is evidence that movement and our bodies like to move. So sliding and gliding, our muscles like to stretch, they like to relax. And so that can help our immune system, it can help our inflammatory response, and it helps our muscle system. So realistically adding that in, and your job for your physio is to work out how to make that sustainable for you. So how to make that something you like to do. We always educate on pain. So what a pain system is, I've touched base on that a little bit. I like to draw, I draw a lot in my sessions, where I like to draw about what's happening with the pain system, why the brain is firing. I always draw two brains, the emotional brain and the logical brain, where the emotional brain adds in all the feelings about the sensory experience. So I think understanding that pain system, and there can be some really great YouTube videos around if that's something that you do want to know more about, but that can be really powerful to helping you understand what's going on when you might have a flare, or what's going on when you feel that it is a bad day. We always teach people how to breathe properly, which sounds bizarre, but how to actually breathe deeper than their chest, because that can help our muscle function as well. And I think the one thing I probably say to every single patient that walks into my office is to let go of their belly. So I think every patient I see will hold their belly in, whether that is something that's been learnt, whether that's something they feel they have to do. But I think that's probably a hill I'm going to die on, is that everyone should let go of their tummy, because your tummy is connected to your pelvic floor, and so it will all hold everything up. So you need to relax your tummy and not hold that in. Much easier said than done, but you know. When should you see a physio? So this picture, for those that watch Bridgerton, like most of the world, is about someone who's left it too late. This person, this person's in a pickle. So when should you see a physio? So I think, I mean, in an ideal world, if I could have all the money in the world, every 13-year-old with period pain would see a physio. And if I had all the time in the world, it would hopefully be me. But I would say that I love treating adolescents, because it's early in the game. So it means that you can educate someone on a pain system early. I would say it's never too late to see a physio. Really, the spectrum, any situation you're in, there will be something that can be beneficial to you. So if you have no problems and you think, no, things are good, go and see a physio to understand about what endometriosis is and what things can be beneficial in the future. Pre and post surgery. So before surgery, the better you go into surgery, the better you'll come out. There's evidence in other chronic conditions or other surgeries that this is the case. If you have any symptoms, pain with sex, bladder or bowel problems, if you are having lots of fatigue, if you're having pain at work, pain with exercising, anything like that, a physio is a real integral part of your treatment care program. If you're feeling stuck or overwhelmed and you just don't know what to do, the physio will often know if it's not them that's going to fix the problem, they will know where to send you. So I think about there's lots of networks. We keep a drive in our clinic of all the practitioners that have an interest in endo to be able to send you to the right person the first time. So whether that be a psychologist or a dietitian or a naturopath or something like that. If you feel like you can't quite get on top of exercise or you can't move well with endo or pelvic pain, then absolutely that as well. But I would say that if you're an adolescent and you've got period pain, like absolutely seeing a physio can be a non-invasive way to be informed. And I think having days off school and things like that, seeing a physio can hopefully optimize that or at least empower the adolescent to understand more what's going on. And I think that long-term, to prevent that central sensitization, educating early is really important. I've put here thank you, but there's a lot of other things we could talk about in terms of TENS unit. Emily and I talked about TENS units before, about them being useful. So I'm just going to pop a few things at the bottom that I am going to mention. So in terms of a TENS unit, I'm not sure how many people in the room use a TENS unit. Not as many as I thought. Yeah. Yeah. So a TENS unit is like a little electrical device, which always sounds way awful when I say that out loud, but it's like a little device that sits on you and it buzzes. It feels like a little buzzing feeling. I won't explain the science necessarily, but if you think about it really simply, that there's a lot of input going on at the level in the spine and it blocks the other input up to the brain. I think if nothing else, it acts as a really good tool. So I think I talk a lot about a toolbox in physio. And I think talk about it literally like a toolbox. If you've got things in your toolbox and you're having a flare or you wake up and you think, oh, I'm not feeling like it's going to be a great day, having things in your toolbox helps that kind of escalation plan of like, okay, I'm going to put this on first. Let's see how we go. If we escalate a little, what can I put on next? What can I do next? So I think the TENS unit is a really good first step. It's obviously not a medication, which is good. I would say I'm a bit fussy on brands. I think some brands are better than others. And that can be as simple as that they don't have cords. So they're wearable so that you can put them on under a t-shirt and no one would know. So it's very easy to put it on to go to work. And those that are designed by people with a lived experience, I think probably are a bit better. So I'm a big fan of TAP Health. She's a New Zealand female founder and she's done really well. She's got a lived experience of endo, but she also provides different sizes for wherever you want to put it on your body. So I also would say they may say, put it on your tummy, but you can put it on your back. You could put it on your upper thighs. There's no rhyme or reason as to why you can't do that. Okay. It also doesn't have to be limited to period pain. It could be used for ovulation pain. It could be used any pain you've got, it can be used.
Thank you.
Yeah. Any questions? Yes. Yes, I can. So I can tell you a little bit about Matilda. So Matilda was born. So Kev is the other co-founder. He's up in the audience. So Matilda was born in 2022. We are a digital innovation platform. So our mission is to improve the lives of people with a chronic disease or chronic painful conditions, starting with endometriosis. So Kev's a physio too, and we're really frustrated about the impact we could have in four walls, but people can't often afford to see physios and to see physio, dietitian, psychologists. It's very frustrating to not be able to afford to see the people that they needed to. So our goal is to be able to make holistic care accessible and affordable. At the moment, we are focused in around optimizing surgery. The reason we are focused in around optimizing surgery is because it's a pivotal point in most people who have confirmed or suspected endometriosis, pivotal point in their journey, and hopefully a time where there can be some shift and change and things like that. And it's a high motivation point. And I think lots of people in the room would probably agree with that it's a point that might be a bit of a, hopefully a turning point. So we offer a 4-week pre and post surgery optimization program where each holistic care practitioner has developed content that can be watched or listened to wherever you are at home. It's taking the burden of appointment fatigue and cost away, so you can learn about what you can do to optimize yourself before surgery and after surgery. But I would say that some of the feedback we get, which is really, which we love, is that some of them will watch it all again, maybe a month or two post surgery, and find huge benefit then as well. So it's not really limited to the surgery, but it is designed around the surgery. So, and the kind of clinicians we have on our platform, we're very, very lucky. We have an incredible psychologist, Sophie Callan, who did her honours in endometriosis care. She's from the Gold Coast. So she's developed all the content around the fears of not being diagnosed, but also how to prepare yourself mentally if you are diagnosed. So, and then how to learn about pacing and things like that. We've got an endometriosis nurse. I'm not sure if some people might follow her on Instagram. She's got a big following. Nikki Campbell from the Epworth Centre. So she's developed all the nursing content. I've done all the physio content. Dr. Jade Acton and Dr. Rose McDonnell have done the gynaecologist content. And Rachel Guerin has done the dietetics content. And she's got a lived experience of endo and has a clinic built around endometriosis. So we've got movement videos on there, so yoga, Pilates, pelvic floor relaxation, all to help you be able to manage your condition at home in comfort without having to go to 50,000 appointments before and after surgery. So our goal is to make that as affordable and accessible as possible for everyone. And I should actually say we also will validate that platform this year through Curtin University, so to make sure that it's beneficial. So my pleasure. Yeah.
Oh, thank you. Okay, well, while we play around with that a little bit, I want to introduce our third speaker, Dr. Kirsten Peters, who leads the Clinical Studies and Biostatistics team at Proteomics International. I would like to thank Proteomics International for co-hosting today as well. Another special shout out. So Dr. Kirsten Peters is responsible for the development and validation of diagnostics in the ProMarker pipeline, including ProMarker Endo. She has been with the company for over 10 years, a long time, and has been a consultant at the University of Western Australia for 15 years and has over 15 years of experience in clinical and genetic epidemiology. Kirsten has extensive experience in data analysis and has co-authored over 40 peer-reviewed journal articles. Thank you for joining us today. That's so exciting.
So happy to be here. Thank you. So good morning. And I just wanted to say thank you to all of you for spending your Sunday with us to talk about everything endometriosis. I'm thrilled to be here representing our team from Proteomics International and to be able to share with you some of the amazing science that we've been doing in this space. We've been developing a new blood test for the diagnosis of endometriosis. Small disclaimer, I had a problem with the font on all my slides, so if they disappear, that's why. Now, I'm pretty sure all of you know what endometriosis is, so I won't go through this in great detail, but we know it's a very painful condition. It affects 1 in 7 women and girls in Australia. It's long-term, it affects lots of people, and it causes a whole range of symptoms. And we know not everyone's symptoms are the same. Severe pelvic pain, heavy periods, sometimes infertility. Individuals can suffer from this intense and chronic pain, which substantially impacts their quality of life. We know diagnosis is challenging. It's often delayed, the average being 7 years. That's a really long time. It typically requires surgery, that's laparoscopy, and this is invasive and expensive. Not only do individuals and their families suffer from this disease, but it costs a lot of money in terms of lost productivity, healthcare costs, and the like. So it goes without saying that early diagnosis of endometriosis can transform the outcomes for people and the healthcare system. And in the current diagnostic landscape, we know that there are huge delays. And this is because the symptoms vary, but from person to person, this causes a lot of challenges. From the onset of symptoms to diagnosis, the delay can range from 4 to 11 years. That's a really long time. There's limited diagnostic tests available. Repeat testing is often required. Misdiagnosis is common. And in fact, there's some numbers saying that 36% of all endometriosis cases are missed in surgical diagnosis. And in stage 1 cases, so that's early stage, that's the most common stage, this can be 50%. Obviously, this leaves many people unable to receive the care that they need. Significant time and cost, repeated doctor consults, many people having to pay out of pocket for surgery. Clearly, a simple, non-invasive diagnostic test would be hugely beneficial in endometriosis. So some of you may have seen this study that we published at the end of last year. This was an amazing, This was an amazing study that brought together a long list of people that were involved, both on the inside but also facing out. And this was in human reproduction and was done with our colleagues in the University of Melbourne and the Royal Women's Hospital in Victoria. So today I wanted to talk a little bit about what this study, what this paper was about. What did we do? So the aim of the study was to identify blood markers of endometriosis that could be used to develop a diagnostic test. This study used 805 blood samples from women, both some who had endo and some who did not. And what we wanted to do was look for unique markers or fingerprints in the blood that indicate the presence of the disease. So how did we do this study and what did we find? Now, this study was conducted over several years in multiple phases, and we identified a very long list of blood markers that seemed to be important in this disease. In phase 1, there was a discovery phase where we went fishing to see what we could find, and then we went through different phases to confirm these markers that were coming up to ensure that they were reliable and real. The markers were compared across 3 clinical groups. We had people with endometriosis, that is, they had confirmed disease, they'd had surgery, diagnostic surgery, stages 1 to 4. We then had a group that were symptomatic controls. They had signs and symptoms of endometriosis, went in for surgery, but confirmed that there was no surgery no endo visible. And then the third group was general population healthy controls. And these women had no signs or symptoms of endo. And what we wanted to do was look at the markers between these different groups, focusing on extremes of disease to try and find what might be significantly different between the different groups. So a result of this long phased approach, we identified 10 key markers in the blood that were linked with endometriosis. We then used these markers in a series of mathematical models to assess different combinations of the markers, and then tested these models for their accuracy in being able to detect the presence of disease. So a combination of these models, and in fact in the paper we talk about 3 models, the combination of these 3 models can be used to generate the final outputted blood test result. So now I'd like to talk a little bit more detail about the best model, which was called Model 3 in the paper. This model contains 7 of those 10 blood markers, plus age and BMI, and it correctly identified severe endometriosis cases, that's stage 4, with 99.7% accuracy. Now, this model, even for milder cases of disease, had really great accuracy, 85% or higher. So what am I talking about? What's accuracy? So here in this particular point, accuracy is measured using a statistic called the area under the curve, the AUC. An AUC of 100% means a perfect test. It correctly identifies every single case. An AUC of 50% means the test is no better than just flipping a coin. And so in the diagnostic space, we really want to get a model or a test that has an AUC of greater than 80%. That's considered excellent and really useful for clinical practice. Now, the picture that I'm showing here is from the paper, and basically the higher the curve, the better the accuracy. And you can see there's 4 different lines, and each of those coloured lines represents the different stages of endometriosis. As I said, the severe cases had the highest accuracy, and then the early stage, stage 1, had the 85% accuracy. You can also see the dotted line AUC of 50%, that's that flipping of a coin. Now, the AUC curve is derived from sensitivity and specificity, and these terms, you may see them floating around. They're also in our paper, and I thought I might just spend a little bit of time talking more about those. Accuracy in this instance shows how well a test correctly detects or rules out endometriosis. Now, this is a hypothetical example, but using the results of Model 3 in our paper. So let's say 100 women with and without endometriosis. Now, all 100 of these women have had surgery, so we know that they have or don't have endo. They take this test. 41 have endo and 59 do not have endo. So let's see what the results for the test show. Now, for the 41 people that we know from surgery have endo, this test could correctly identify 40 of them. So that's our sensitivity. But it misses one person and says, no, she doesn't have endo. And so obviously this is a problem because it would delay treatment for that person. What about the people who do not have endo? So the test correctly identifies that 57 of them are negative and yes, they don't have endo. So that's our specificity. But 2 of these women were told they have endo, and this is obviously a problem. This causes unnecessary worry and likely further testing for these individuals. But overall, you could say that this example shows that the test is very accurate because 97 of those 100 were correctly identified. Let's talk a little bit more about current diagnosis methods. Now, none of these methods, including our blood test and other tests, are 100% reliable. They need to be used together. The gold standard is still laparoscopy because this allows direct visualization and biopsy, but it's invasive and expensive. There's imaging tests such as MRI and ultrasound, and they are helpful for detecting more moderate or severe endometriosis, but they're not sufficient to rule out disease. MRI is great for deep endometriosis, but it's more expensive, not always available, and it may miss the early or milder cases. Ultrasound is also great for large lesions such as ovarian cysts and deep disease, but it too may miss smaller lesions in milder cases. Now, the accuracy of the transvaginal ultrasound depends hugely on the skill of the person performing the scan. Now, you may be curious, well, what are these 10 blood markers that we've identified? What do they do in the body? So all of them actually play very important roles in the body. Some are involved in blood clotting, immune responses. Some affect how the body processes fats. Some protect against cell damage and defending from harmful molecules. Some are involved in immune system regulation and how we fight infections. And some are important for tissue growth and repair. Some of these markers have multiple roles in the body, and you can see from this list that this emphasises the complexity of this disease. Now, the table shows the 10 markers, the names of the markers, and the 3 that are in orange are 3 that have been previously linked by other people as associated with endometriosis. So why is this test that we're developing so important? I think this test provides hope for the future. This could make diagnosis faster easier and more accessible for women worldwide. A highly accurate test means fewer women will experience years of delayed diagnosis. This test could significantly speed up that diagnosis. A simple blood test reduces the need for surgery and imaging, which lowers risks, costs, and waiting times from these methods. Earlier diagnosis equals earlier treatment, which may slow down the disease progression and improve quality of life. Reliable results help doctors make better treatment decisions. So what's next for ProMarker Endo? So we will hopefully be launching soon. We're currently working to make this test widely available so that it can be run in pathology labs everywhere. We're improving the accuracy so that there will be a traffic light system where a test result will be a low, moderate, or high risk. And this will help guide a more tailored treatment decision by the doctor. Further studies are needed to confirm how well this test may work in different ethnicities, age groups, disease stages, and, for example, fertility clinics. This test could be a potential game changer, transforming how doctors diagnose and treat this condition. So I'd just like to thank you again. I'm happy to take a few questions. There's a few of us in the audience, so please come and find us if you'd like to ask anything. We also have updates on ProMarker Endo, so if you use this QR code, you can be looped into those. Thank you.
Do you have any questions? I'm going to introduce our fourth speaker, specialist gynecologist and AGIS accredited advanced laparoscopic surgeon, Dr. Copson, who has a special interest in the management of endometriosis and in complex laparoscopic surgery. He has expertise in the management of fibroids and menstrual disorders in the form of both medical management and minimally invasive surgical options. Thank you for joining us today. If you will come to the podium. Good job. Very sharp. Very sharp.
Can everyone hear me okay? Yeah. So yeah, feel free to ask any questions. It's a nice opportunity. I thought I'd put this, there's a lot of information to take in with endo, especially if people are just diagnosed, just had surgery. So more of a logistical, what do I do when I see the gynecologist? If you have any questions, if you have conflicting information, which you've heard before, which I'm sure you have, then put your hand up and I can answer it for you. I do lots of endometriosis, probably 80 or 90% of my practice, but general gynecology as well, and run a private practice as well as work out of King Eddie's endo unit. And we see all the most complex cases of endo in the whole state of WA. So just running through what we'll talk about today. What do I need to prepare? Well, not too much, but there's some things that can help. Who is my gynecologist and what's their training? What do all those confusing letters mean at the end, which no one knows or understands except for us? Should I try medication? Should I have surgery? Should I have surgery again? Should I have a hysterectomy? I included this. It was asked by someone from the audience because there's a bit of conflicting information and what would be the benefits and the downsides of doing that. Why do I still have pain after these treatments? Another question that was called in was about these new PBS medications, so subsidised by the government, Ryeco and Vasan, and are they right for you and what are they? Are they new? They're not. It's just the government's decided to start paying for them finally. And will menopause make everything better was another question that was asked. So what to prepare? You don't really have to prepare anything. I'll go through my first appointments where we just sit down and get a comprehensive history from you. And the most important thing is your symptoms. So it's more finding a gynecologist that will listen to your concerns that you have. And as doctors, we don't have a great history of listening to patients, unfortunately, as is shown by the long delay in diagnosis. It is improving, but if you see someone that does a lot of endo, then they will obviously listen to your concerns and address those. Write your questions down beforehand. The first appointment is a lot of information. And so if you've got any specific questions, then we'll run through them at that first appointment. a support person can help with that because they'll know what you needed to know from before. Current and past medications, more just from an endometriosis point of view, what have you tried before, so we know that if it's effective or not effective and what other treatment options there are. We can always follow up ultrasound and MRI reports, so that's not a big deal. And information on previous surgeries, I'm not so fussed about that it happened on the 1st of January 2019. I kind of just want to know it happened 5 years ago versus 2 months ago, yeah? Because that does change what we talk about or what is most likely the cause of any ongoing pain. The stage of endometriosis can be tricky. We did a big study at King Eddie's, a tertiary unit, and looked at if we could tell the stage of endometriosis from operation notes, and often we couldn't, yeah? So it's great if you know, but if you don't know what stage of endo you have, it's not a big deal. It's more to give an idea of how much there was, how complex any future surgery might be if you were to have surgery, which not everyone needs. An operation report can be helpful. Photos can be helpful, but sometimes they're blurry. So if you don't have photos, if you don't have an operation report, you don't know what stage of endo you had, it's not a big deal, but just little things that can help. What I'm most interested in is your experience. So what was the surgery like? Did it help your pain? How long did it help your pain for? And what other treatments have you tried? And what's your priority for management going forward? So how my first appointment looks, listen, that's not for you, that's for me to sit down and shut up and not say anything for the first 5 to 10 minutes so you can tell me what your issues are. But symptoms I might ask you specifically about, if you haven't mentioned them, when you get your pain. So do you get pain when you have bleeding? Do you get pain with intercourse? In my opinion, an aching pain after intercourse is diagnostic of an overactive pelvic floor, and you should see a women's health physio. Do you have pain with bowel motions? So that can relate to more severe endometriosis involving the bowel, but it can also relate to the general inflammation from endometriosis as well. Do you get pain that's not related to your menstrual cycle? Do you get signs of what we call neuropathic pain? And I'll explain what that is, but pain radiating down your legs, shooting across your abdomen might be an issue with underlying nerve damage. Maybe initially due to endometriosis, but we need to tackle it as a separate problem as well. And if you have had surgery before, how long did it help for? Did it help? And what other treatment have you tried before? So just some general things to skim through about who your gynaecologist is, just because we have all letters behind our names and we think that everyone knows what they are. Usually GPs don't know what they are, and patients who come and see us definitely don't know what they are. A gynaecologist is someone who's done specialty training in O&G, so that's 6 years of training. If someone says they're an advanced laparoscopic surgeon, that's not a protected term, so anyone could say that. I've done an AGES Advanced Laparoscopic Surgery Fellowship, so that just means I do a high volume of endometriosis surgery. There's one trainee in WA for every 2 years that does all of the most complex endometriosis cases in WA and is trained to do any stage of endometriosis surgery. Should I try medication? So look, this isn't going to apply to everyone, and this is a general skim through. That's why I encourage you to ask questions about any conflicting information that you've received, but just to run through the general treatment options for endometriosis, which I'm sure you're well aware of, but more a bit of an evidence base of why they work or why they might not work. So pain relief, the best evidence is around anti-inflammatories. So anti-inflammatories are ibuprofen or Nurofen. Often I use naproxen or naprogesic, it's a bit more effective. Voltaren, it comes as a suppository, so the look in people's faces when I suggest it is quite frightened, but it is very effective for severe exacerbations of pain, the pain where you can't get out of bed or you don't want to go to work, or people often use celecoxib as well. These nerve agents, so a lot of it, I mean, some people describe as masking the pain. I say, look, you've got chronic pain, we need to treat it as many different ways as possible to make it effective. Nerve agents are typically for people who have neuropathic pain, so underlying nerve damage in their pelvis. They can make you drowsy, so you take them at night time. Nortriptyline, amitriptyline have the best evidence. Pregabalin has some evidence, and duloxetine some people use as well. These are originally used as antidepressants and repurposed, but they are very effective for nerve pain. Hormonal treatment works for about 70% of people with endometriosis. There's not one amazing pill that's the best treatment for endometriosis there is, and that's why we talk to you about what you've tried and would you be willing to try other things as well. And it can be a bit of trial and error. Some people need to try 3 or 4 different pills or hormonal options until they find the right one. Common combined oral contraceptive pills are Levlin, has been on the PBS for years. Yaz and Yasmin have just gone on the PBS, or Zoli, progesterone-only pills. Slender gets a big run for endo. There's yet to be a study done for Slender on endometriosis, but we use it because other pills work. In regards to evidence, Vasan probably has the most evidence for endometriosis of how effective it is. That doesn't mean it's the best. It just means a lot of people have studied it and say, hey, this works. Depo-Provera can be great. The Mirena or Kylena. Mirena probably a bit better than the Kylena because it's a bigger dose of the progesterone. GnRH analogues, we'll talk a little bit about this. Most people don't need to know about them, but just it's been in the news a lot recently. So I'll run through the method of how they work, but basically they come in either an injection, so Zoladex, or Rayako is in tablet form. Rayako is a new one that's just been on the PBS. They're very effective for endometriosis. There's no doubt about it, as is menopause, because they put you into menopause while you're taking them. So they bind to a part of the brain and shut down your ovaries and stop estrogen and progesterone release. And that's why they're so effective, because they can have significant side effects because of that. I'm not saying they're not appropriate for people. They are. I use them quite frequently for people who have really severe endometriosis or have had surgery in the past, and any further surgery would be really high risk and complex, or they've tried other treatment strategies that haven't been effective. But you do need a lot of counselling around them because they can have significant side effects. So how they work is usually, we don't have a pointer, do we? That's right. Usually a part of your brain releases gonadotropin releasing hormone. You never need to remember this, it's just to explain how they work, yeah. It acts on another part of your brain called the pituitary gland that releases follicle stimulating hormone and luteinizing hormone, which act on the ovaries. So all these analogues do is they bind to the part of your brain and soak up those receptors to stop any GnRH from being released. Therefore, they dramatically reduce your estrogen and progesterone production from the ovaries. Because of that, the side effects are from low estrogen levels, so hot flushes, loss of bone strength, sleep issues, and mood issues. But these medications come with a low dose of add-back hormone replacement therapy to help treat a lot of those symptoms. People actually do have pretty good quality of life on them, but they're probably not what your first go-to would be if you haven't tried other treatment. Should I have surgery? Look, surgery is not for everyone. Part of our first appointment, I'll never do a procedure on someone unless I've explained all of this information to them. Surgery can be very effective. We spoke about the downsides, that it's invasive, the costs mostly as well from the time off work as well. So I don't use surgery as a diagnosis. I use surgery as a form of treatment. So diagnosis I can get from your history and your symptoms tell me it's suggestive of it. If you've had endo in the past, or a very good quality women's imaging scan that says you have endometriosis. So surgery I don't use. I try and encourage people not to have it just to tell if they have endo or not. I use it as a form of treatment because 80% of people who have surgery will experience a significant improvement in their pain. I always counsel everyone that's not 100%. So 20% of people have surgery and doesn't change their pain, and 1 to 2% of people surgery makes their pain worse. Generally, the people who it makes their pain worse, they're not coming to see me and say, look, I have this cyclical pain, it's around my period, that's when it's the worst. They have pain every day that's not changing with their cycle at all. They have a lot of other symptoms, signs of nerve damage in the pelvis, shooting pain across their abdomen. And that's not saying there's no role for surgery in those people. They're just at slightly higher risk that surgery could exacerbate those nerve problems. And really important, I talk with people, if you're going to have surgery, I strongly encourage using hormonal treatment as well, because you want to, if you're having this big surgical procedure, you want to reduce the chance of endometriosis coming back, so you don't need other treatments in the future. Looking at surgery for fertility outcomes. So endometriosis can affect fertility. I explained to everyone it does not mean that it will affect fertility. So for anyone who wants to try to conceive, I say, look, try to conceive. Give it 6 months, and if you haven't fallen pregnant in 6 months, then we'll do some tests and look for lots of other causes that could be causing fertility issues, and endometriosis could be one of them. Surgery for people with endometriosis who have issues falling pregnant can improve the chances of falling pregnant naturally. So Stage 1 or stage 2 endometriosis is smaller deposits, not so much these big lesions in the ovaries. It does improve chance of pregnancy. If you have an endometrioma, so a collection of endometriosis in the ovary, surgery improves the chance of falling pregnant naturally, but it can affect your overall egg count as well. So that's something we'll have a chat about before going ahead with surgery. Deep infiltrating endometriosis, I don't know if you've heard of it before, is just a term of more severe disease. So the evidence is unclear. It's not ethical to see people with severe disease, say the half of you are going to have surgery and the half of you aren't, and we're going to see if you fall pregnant in 12 months. We're not guinea pigs, so we don't do those types of studies anymore. The general consensus is it probably does improve your chance of falling pregnant naturally, and the international guidelines say if you have symptoms such as pain, having surgery is a reasonable option if you're having fertility issues. Should I have surgery again? Yeah, and this is a tricky one, and this requires a bit more counselling. So if you've had surgery in the past and you're still having persistent pain, you've tried other treatment options such as the pain relief we're talking about or hormonal treatment, and you still have pain. Or you had surgery and it improved things, you're great for 3 or 4 years and now your pain's coming back. So it's not a clear answer, it depends. And a lot of it depends on what your preference is once you're aware of the information. I don't have hard and fast rules that I don't do repeat surgeries. In an ideal world, you'd have no surgeries or one surgery and that's it, but it's not an ideal world. People have recurrence of pain, people have recurrence of endometriosis. So things I want to know related to the operation report or the photos, was it removed all last time? Who did your surgery? How severe was the disease? And is there any disease that was left behind? Sometimes we're not always told that information, unfortunately. Did the last surgery help your pain? So if you come and see me and you've had 4 laparoscopies before and they all helped your pain for 3 months, and then you say, look, repeat surgery, we're kind of banging our head against the wall and expecting a different outcome. But if you've had repeat surgery and it helped you for a few years and now you're getting pain back again, there's a reasonable chance that having another surgical procedure will improve your pain. But I'll always talk with you about other options to manage your pain as well. Related to when was your last surgery? Ideally 5 years between surgeries. That's an ideal world, just related to the chance that if you have a laparoscopy, sometimes we don't find anything. So having another laparoscopy within 12 months of your last one, there's a 90% chance that there's no endometriosis seen. So 10% chance that there is still. So that's like, we don't completely discount it, but as long as you're aware of those stats. Whereas 4 or 5 years after surgery, there's upward of, can be like for some people, a 50% chance that they'll have some endometriosis there. Repeat surgery does help with pain, so it is very effective, but your first surgery, if it's complete, is going to be your best surgery. So repeat surgery can improve pain a lot, but the magnitude, how much it improves your pain and the duration won't be as effective as the first one if the first one treated all of your disease. And always counsel people about, look, what if we go in and there's no endometriosis there? What do we do? Should I have a hysterectomy? So this is a common question people ask. And there's a lot of conflicting information saying hysterectomy is great and hysterectomy is not a cure for endometriosis. Unfortunately, there is no cure for endometriosis, but there's a lot of effective treatments. Why would you have a hysterectomy? If your family's complete or if you don't want children, having a hysterectomy is associated with higher level of improvement of pain than laparoscopic treatment of endometriosis alone. Especially in people who have had a previous laparoscopy for endometriosis and they're coming back for repeat surgery, because you're not just doing the same thing, you're doing something additional which might treat any pain of contraction of the uterus. The uterus releases a lot of what's called inflammatory cytokines during the menstrual period, and that causes pain. And prostaglandins, that's why Nurofen or anti-inflammatories work so well, because they target those. And a lot of people who have endometriosis have adenomyosis. So adenomyosis is the lining of the uterus occurring within the muscle layer, and the hysterectomy is curative for adenomyosis. It's the only cure. So yes, there is good evidence that a hysterectomy would improve things. Hysterectomy has been shown to reduce the need for surgery in the future as well, to reduce the reoperation rate because it's more effective. There's common questions that people ask, well, what if I haven't had kids or I don't want kids and I'm in my 30s? I saw 2 gynecologists and they said they won't do it. look, that patient autonomy or people's autonomy is the most important thing. That's how I approach things. My role is to give counselling about what the risks or benefits could be. The reason people you might get that explanation is the risk of regret of a hysterectomy. So someone at the age of 30 who come and says, look, I definitely 100% don't want kids in the future, I want a hysterectomy, 30% of them will regret that. And that's a study that was done where they said there's a 100% chance I definitely don't want my uterus. So it does need special counselling, but it doesn't mean that, I mean, your autonomy and what you want, I think ultimately is the most important thing. It's your body and you can choose to do with it as you wish. But just having those sensible conversations about what the expectations are and how beneficial it could be. Would you remove the ovaries? Look, generally for most people, in summary, no. Because you go straight into menopause and there's some risks associated with that. You can negate a lot of those risks by replacing those hormones. So a low dose of estrogen and progesterone. You say, well, why would you take the ovaries out and then just give me the hormones anyway? You give it at a much lower dose. The reason people might remove the ovaries if they have really severe disease or if they've had multiple surgeries and any repeat surgery is going to be really complicated, they would choose to have the ovaries removed. And I do it sometimes, often, I mean, we get all of the most complex cases of endo, so we do this sometimes. There's an 8 times lower chance of having a recurrence of endometriosis if you remove the ovaries. But the risks of going into menopause earlier, those things we spoke about before, and those medications, so issues with bone strength, your heart health, lots of different things we'll talk to you about. So generally applies to 99% of people won't have their ovaries removed. Another question that came in was just what surgical innovations am I excited about? So one I use quite frequently, like at least every week now, is a thing called indocyanine green. So this is a special dye that during laparoscopic surgery for endometriosis, I do a cystoscopy, which is a look inside the bladder. I put a catheter up into the ureter, which is a tube that runs from the kidney down to the bladder, and I inject some dye into the ureter. This dye binds to the skin that's lining the ureter and it stays there for 8 hours. And then when I do a laparoscopy or keyhole surgery, I use a special light and the ureter shines bright green during the whole surgery. The highest, I mean, the risks of surgery are injuries to other organs. And the ureter always, endometriosis is, as you probably personally experience, a pretty nasty disease, and it seems to always be over the ureter. So what this does, it helps reduces the chance of injury. It means that we're not doing this big dissection in the pelvis just to cut out, or just to find the ureter. You can see it straight away, and it increases the safety. I apologise for the gnarly surgery photo without giving you warning. So other common questions I get is, I've done all these treatments you told me to have, or I've had these before, why am I still in pain? So endometriosis is a complex condition. All of these can be effective, but there's other causes of pain that could be happening at the same time, or there's downstream problems of endometriosis as well. So myofascial pain is a very fancy way of saying muscular pain or musculoskeletal pain. So this is part of the questions we talk about. Do you get increased pain with certain activities? Some of my patients describe when they lean over or pick something up, they get a lot of pain. Or with intercourse, they get an aching pain after as a sign of a hypertonic or overactive pelvic floor. So I would encourage a lot of people who have endometriosis or are having surgery or still have persistent pain to see a women's health physio, and they can manage that long term. It's not an overnight fix, but it's part of the overall management of your pain long term. Neuropathic pain and central sensitization, you never really have to remember these terms. I'll just run you through why they happen. The inflammation caused by endometriosis can cause underlying nerve damage in the pelvis. So normal for when, I don't know if you do a lot of work around the house, if you accidentally cut your finger or you hit your finger with a hammer, you get a thing called nociceptive pain. So the pain fiber runs up to your brain and says, I'm in pain. That's normal. What neuropathic pain is due to repeated insults and pain. So repeated release of the toxins associated with endometriosis causes those nerves to continually fire off pain signals and cause an elevation in those pain signals, or firing off pain signals when there's nothing there anymore. So the endometriosis has been cut out. Central sensitization is a similar thing, but it happens with the brain. So the part of the brain which picks up pain signals, instead of dampening that down like you become tolerant to a medication, the opposite happens. And your brain increases those areas and increases the sensation of pain when you receive it. And we'll talk about different treatment options for that as well. Adenomyosis is related. A lot of people who have endo have adenomyosis. So that's the lining of the uterus or similar tissue occurring within the muscle layer. So just briefly on neuropathic pain, this is how a normal pain signal works, but just repeated inflammation causes nerve damage, and those pain fibers just continue to send signals saying I'm in pain, and there might not be something there anymore. Central sensitization occurs because of those increased regions of the brain, but you can have cross sensitization. So if you have pain from endometriosis, but you also have that myofascial or musculoskeletal pain, if you also have problems in the uterus, such as adenomyosis in the bowel or the bladder, then all of these are constant pain drivers. So while it's really important to treat the endometriosis, and that could be with hormonal treatment or even surgery in select people, it's also important to manage the central sensitization as well. But treating those things like endometriosis stops it from being a continued driver for the pain that you're experiencing and stops it from getting worse. So what else can I do? Women's health physio to manage an overactive pelvic floor, any possible muscular pain. A pain specialist is very good. So these are usually anaesthetists who are trained with an interest in pain, and they will deal with the neuropathic pain or the central sensitization. A good pain specialist, well, the good pain specialists I send to don't just do procedures like nerve blocks. In fact, I don't think my pain specialist I send all my patients to has ever done a nerve block for a patient. They work on a more holistic pain management. So looking at, yes, analgesia, yes, those nerve agents, looking at low impact exercise, yoga for pain, mental health support, because I'm not saying the pain's in your head at all, but ongoing pain can be debilitating for your mental health, and just having that extra support as well. Dietitian can be great. Look, the evidence is a little bit grey that there are this amazing be-all end-all, but there definitely is some good evidence for low inflammatory diets. So seeing a good dietitian with an interest in women's health can help overall. Education and being at the central of your pain and taking kind of responsibility for all of these things has been shown to improve pain outcomes a lot, but it's a lot just for you to deal with. So important to have the support person, have a good GP as well. Mindfulness, it sounds like wishy-washy. Why would mindfulness and meditation help my pain? It's been shown to dramatically improve pain in people, which is very good evidence for mindfulness. Acupuncture has some evidence as well, or yoga for pain, low impact exercise. And often I'll talk with people, yes, I'll do surgery or do medical treatment, but ideally you would be doing all of these things. And the last question, I suppose, is will menopause make it better? Was a question that came in, because often people get told it will, and some people go through menopause and it doesn't. Menopause, just looking at the audience, not making any age judgments, but it seems to be a long way away. The average age is 51, yeah? So generally, yes, things get better after menopause. Endometriosis recurrences after menopause are rare, for reassurance. You can sure find case studies, but they are very rare. The important thing with hormone replacement therapy, I haven't put that on saying take it, but it actually is very safe and very effective for menopausal symptoms. But what I've done there, the EMP is estrogen and progesterone. So if someone has a hysterectomy, for example, the only point of progesterone is to protect the lining of the uterus. And the temptation is, if you've had a hysterectomy and you want to go on hormone replacement therapy, just to take estrogen. That will probably make your endometriosis worse. So even if you've had the uterus removed, if you're going to go on hormone replacement therapy, always take estrogen as well as progesterone. A lot of the reason why pain might be ongoing after menopause may not be directly related to endometriosis, but downstream issues. So pelvic floor dysfunction and muscular pain, scar tissue, neuropathic pain, and central sensitization, which we've spoken about. And we do know that although the estrogen isn't released from the ovaries as much, adipose cells or fat cells in the body do cause hormones to be transformed into estrogen. We do find that weight loss for some individuals can help pain as well with endometriosis. So that's a lot of information. I hope someone will ask a question, or if you've heard of anything about myths, you've been told conflicting information that someone told you and you don't know what to believe. There's a lot of fantastic information out there that endometriosis does, or lots of info on Jean Hale's Foundation or Endozone, and there's a lot of, unfortunately, rubbish information out there. My general summary is just find the tailored treatment that works for you. Find a good GP. The general treatment options, anti-inflammatories, hormonal suppression can be very effective, but isn't right for everyone. Surgery can be very effective, but isn't right for everyone. And there's other surgical procedures as well, and also having that supportive care team around you to provide these other options to improve your pain long term. That's all. So if you've got
Do we have any questions? Oh, yeah.
as in more of a risk of getting scar tissue. Yeah. Yeah. So yeah, without knowing like the specific example, it's difficult to give specific advice, but generally endometriosis can cause scar tissue. Surgery can cause scar tissue. So where that might come from, look, repeat surgery, as we've said, it's not as effective as the first one, but still can be very effective for pain relief. If we're looking at solely from a scar tissue point of view, where that might come from is if you're doing surgery just to divide scar tissue. So if you have a scan that says there's scarring in the pelvis and no signs of endometriosis, although that doesn't exclude it, but let's say hypothetically you have another laparoscopy and there's just scar tissue there, and you have the benefit of hindsight, is would you do surgery just to divide scar tissue, even if there's no endometriosis? And the answer is no. So with knowing that there would be no endometriosis there, treating scar tissue is not effective. When you're going for surgery, you should be doing a procedure. So dividing scar tissue should help you perform a procedure, but it should not be the procedure, because surgery will just, that scarring will just reform. So we do counsel people if they have a scan that says they've had surgery before and says the ovary is a little bit stuck down. Look, that might be because of a recurrence of endometriosis. And if there is endo, then surgery can be beneficial. But there is a risk that it's scar tissue. And if we go in and just divide scar tissue, it doesn't help your pain. Does that kind of answer your question? Yeah. Yeah. Mm-hmm. Yeah, as in, well, for anyone it could, yeah. So a lot of this, try and tell people you can have endometriosis and findings on scan, but the most important thing is your symptoms, yeah. So we're looking at pain management. So for anyone, it's like if a marina improves their pain so dramatically that it's gone, they might not need surgery again. The physical endometriosis will still be there. It's not going to magically make it go away, but what's the most important part is your symptoms. If you, in the setting of having surgery and stopping endometriosis from growing back, then yes, hormonal treatment can stop it from growing back. But a lot of that is probably accounted for the fact that sometimes it would go back, but you don't have symptoms because you're on hormonal treatment. And that's actually the most important bit. And so I strongly encourage anyone who's having a surgical procedure to not just rely on surgery, have surgery plus hormonal treatment as well. And the marina is a very good option. Yeah. Mm. They're different, yeah. Yeah. Unfortunately, the public system does have a long wait. I know for our clinic, it can be upward of 12 months. Public, yeah. Private varies on who you see. I'll make sure cases with significant endometriosis I see within 2 to 4 weeks. But yeah, public, in an ideal world, you wouldn't have that difference in wait times, but that's the difference in government funding and availability. Yeah. Yeah, the difference in private and public, the main benefit of public is there's no cost. It's covered by the government and it's a really good service. The downside is the wait time to be seen, the wait time for surgery, and sometimes the lack of continuity of care. So you might see a few different people. In the endo clinic, we all work as a very tight group. We all practice very similarly, and there's a few of us there. But yeah, you might see someone different at each clinic. Yeah. Yeah, it's a great question. And the pill is designed to take back to back, one active pill every day, and that's it. Apparently the idea of having placebo pills every month was brought in because the Catholic Church didn't like the idea of women not having their period. So it's designed to take an active pill every day. And your best treatment, if you get painful periods, doesn't quite make sense to get your period every month still, or even every 3 months. There was this previous thought that I don't know where it came from general people or from doctors, that you should at least have your period every 3 months. I think that was based around that we know that women who have PCOS who aren't having their period every 3 months, they have a higher risk of endometrial cancer or precancer. Therefore, we thought, oh, it must be because you have to have your period every 3 months. Completely different condition. The pill reduces the chance of endometrial cancer. So they've since done long-term studies saying if you just take the pill, even if you don't get your period at all, is there any risks associated with it? There's not, of doing it versus cyclical. And in fact, it reduces your chance of ovarian cancer by 60%. You take the pill for more than a few years. So very beneficial. That's an ideal world. It's not always possible. So some women take the pill and they can't. They have to have their period every month, or they can get 2 to 4 months in and they get breakthrough bleeding. My advice for that is stop the pill for 4 days, load up on anti-inflammatories and your other support measures that you've got in place, have your period, and then restart. And it might be that over a few cycles you can skip it completely, or it might be that you get 3 or 4 months and you know you have to have your period then. But yeah, your goal should be to take it back to back.
One last question.
Don't say sorry.
With endometriosis, PCOS, pre-parent sickness, what would your couple be on that?
Yeah, look, it's, again, you've kind of got to put it in the context of everything, but like general advice would be, I'd use, if someone came to see me with those issues, I'd say, look, have you tried already? Or are we talking about future issues that you may have? Because generally my advice to people is I get surprised all the time. So I see people with stage 4 endometriosis and they've been told before that there's 0 chance of them falling pregnant, and they fall pregnant naturally. So I never tell people any definitive things at the moment. I say it's higher likelihood. So with those conditions, sure, endometriosis can impact on fertility. PCOS can, in that sometimes women aren't ovulating every month. But there's very effective treatment to bring on ovulation every month. And there's still really good fertility outcomes with those conditions as well. So generally my advice would be, yes, a lot of things can affect fertility, but I still encourage people to try. We like to think we're really smart and we can predict all these things, and we can't. Your body's much more complicated. So try naturally to conceive. If you know you've got endometriosis, maybe don't give it 12 months, give it 6 months and see. While you're doing that, sure, you can do some other investigations to make sure there's no other issues. So if you're trying naturally, so assuming obviously you have a male partner, get them to do a semen analysis. You could do things like scans just to check and see. You can do those ovulation kits. If we're looking at someone who doesn't have a male partner or would need a sperm donor, then that's a different story. It's going through a fertility clinic to have a chat about your options and the different fertility treatment options, but they are all very effective, especially for PCOS. The issue is not ovulating, so taking very effective medications to help you ovulate. And endometriosis, either making sure there's no other reasons. Surgery for a laparoscopy can double the chances of falling pregnant naturally, or there's all of those other fertility treatments as well. So yes, it can be more difficult, but doesn't mean it's not possible.
Thank you. Thank you. Thank you. Great. I'm going to one of the questions after. I'm definitely going to hunt you down for questions after. There we go. Let me find our last speaker before we meet in the next room for some nibblies and some drinks. I'm going to do a quick introduction, just Alt-Tab until you find it. So for our final speaker, we have Clementine Crowther. So Clem is a passionate gender equality and endo campaigner with nearly 2 decades experience in advocacy and communications work across Australia for purpose and not-for-profit sectors. So currently she's a senior advocacy advisor at Minderoo Foundation, leading the philanthropy's external efforts in gender equality systems change. Thank you for joining us today. She'll be taking us through her patient experience with endometriosis. Again, tears. I'll probably sit right here so you're not alone.
Hi, everyone. It's an absolute pleasure to be here. I've been managing endometriosis. Oh, what was that? Oh, yes. Sorry. I just got straight into it.
Yeah, keep going.
Actually, before I start talking, because I talk a lot, I will acknowledge the traditional owners of the land in which we gather today, the Whadjuk people of the Noongar Nation, and I want to pay my respects to their elders past, present and emerging. And I also obviously extend this respect to anybody, any other First Nations people in the room today. As I was saying before I put it on the proper screen, I've been managing endo for 25 years and I found today really overwhelming. So I don't know if anyone else is kind of sitting there going, that's a lot of information. I've been on this walk for a really long time. In fact, I don't know if that's me when I was 12. And that's when I first experienced endo. And yeah, looking at that young girl who had no idea of what ovulation and periods really were other than what I'd been taught in Year 5 health class. And to think that the experiences I was going to navigate all kind of started at this point it's quite overwhelming as an individual. I was going through my old photo albums last night and found that photo. And I actually remember that was on school camp in Year 6. And it was like the week before I got my periods for the very first time. So it's kind of a real before the storm, the shit storm started. Sorry to swear, I'll keep it real in this one. But I guess today I'm going to go a bit through my journey, the things I've experienced and the things I've learned. And I guess I really want to be a bit of a talking point through the different waves and the different things that yeah, you can experience during this walk. And I just want everyone who's going through it to know that you're not alone. It's a really, it's a full-on journey. So 12 was when I first experienced it. 13 was when I first questioned my experience, but was told it was normal. 14 was when prescription pain meds became a very monthly regular. I would say I was addicted to Nurofen Plus from, about Year 9. 15 was when I missed the first day of my first job. 18 was when I first heard about it. So no one had even mentioned the word endometriosis to me until I was 18 and I had a friend who actually had also been diagnosed. 19 was when I had my first invasive test. 21 was when I first saw my first specialist. And 22, on my birthday, was when I had my first laparoscopy and my official diagnosis. So I was a proper 10 years from symptoms to, I guess, diagnosis. I'm 36, somewhere in that age bracket. And so I guess that was 20 years ago when I first started to experience it. And I do think, well, I hope the experience has changed a lot from what it was to now, but I know that there are certainly a lot of similarities and a lot of things that haven't shifted. And yeah, keen to, I guess, unpack them a little bit. So what have I learned across 25 years of endometriosis? So there's me as my 12-year-old self through high school, my young years going through university, getting married, having my first baby, having 3 babies, and today where I'm now working and I guess going through life as a mum who still has endometriosis. So my journey to diagnosis, as I just covered, was long and confusing. I had no idea what endo was. My doctor, who was an incredible doctor, my GP, and is still one of my favourite people in the entire world, had no idea really what it was either. And she was incredibly highly regarded and is still wonderful. I remember sitting when I first was meant to start my first job at a bakery in St Ives in Sydney. I don't know if anyone is familiar with Sydney. I remember having to call in sick because I was sitting in the bathtub and I had my period and it was so painful that I was pinching my arm till it bruised because it was the only way I could distract from the pain that was going on in my pelvic region. And I remember sitting there thinking, how is this normal? Like, how is a 15-year-old am I feeling so in the depths of this that I can't go to work, I can't go to school, but everyone's telling me, just take some Nurofen and you'll be fine. This is the experience. This is what it is to be a woman. I remember talking to my PE teacher when you would learn about all these things, and she's like, yeah, you know, that's just part of the journey. I remember my GP sending me off for all types of things and going, yep, that's just, it is what it is. And I think, and this is probably the gender equality bit in me, I think as women in particular, we are often expected to mask or to hide our symptoms for the comfort of everyone else. And I remember sitting in boardrooms, you know, when I was young and just starting out in the professional world, and being in such agony that I would go to the bathroom and cry for 20 minutes and come back, and people thought I was, you know, crazy or something was wrong, but I was so uncomfortable. But it was my problem to manage, not everybody else's. And that was really hard, and it was really isolating. And also we didn't talk about it nearly as much as we should have. I think there's something in finding your community, and I'll get into that in a second. But when you have people around you who you can be open with, the journey is so much less scary, because that guilt and that shame that you harbor as someone who, why can't I just function normally? Why can't this work? You feel less like it's your fault, and that there is a system around you who can support you and uplift you. But we need to be there for each other and speak openly, because I think there's so many more people out there dealing with these symptoms than we probably give credit to. So yes, the expected to carry on. Attempts to manage my symptoms. I reckon I've pretty much done everything. I went on the pill for many years. I had a Mirena for many years. I've had surgery, and then I've had more surgery. I've done anti-inflammatory everything. So you name it, I gave it up for about 4 years. That was coffee, dairy, sugar, soy, and gluten, which doesn't leave much, particularly given that I'm vegetarian, out the other side. But it did work. It did help a lot, having an anti-inflammatory diet. I went into the full craziness of making sure that, like, my skincare didn't have anything that could be a hormone disruptor in it. I went down the path of making sure that I only ate seeded bread that was fermented in certain environments, because I was told that that was going to help. And it did help to some degree, but I think it's also not realistic to some degree. And I think my advice through that experience is, when you go down the path of figuring out what you can do outside of surgery, and I completely agree, having a Mirena post-surgery was such an influential thing for me. I think that was significantly helpful, is not putting the pressure on yourself. I actually almost developed a bit of an eating disorder because I was so scared of eating the wrong foods and how that would influence my body, that I got really sick because I just stopped eating because I was scared of eating the wrong thing. And as a result, that compounded and had even more issues, and that probably didn't help mentally as well. So there's a whole bunch of ways that you can go to manage your symptoms. And what I guess I'm trying to get at here is, it's important to explore what could work for you, because there are many different ways that can, but also creating space for yourself in that, and not putting too much pressure on yourself, because we are human and we are all trying to just figure this out. Exercise, pelvic physio. I have a wonderful pelvic physio. I'm really bad at doing my exercises for it. She gets on my case every time I see her, but we're forging forward and giving it a red hot go. Pregnancy and breastfeeding. I was fortunate. I was able to fall pregnant relatively easily, but I did have a number of miscarriages, and that was just part of my journey. I personally found that my endo calmed down a lot while I was pregnant and breastfeeding, but now I'm out the other side of that. I am back in the fiery hells of endo, and I'm on the Endo WA board, and I've missed many an Endo WA meeting because I'm sitting in bed, the lights turned off, and I've got the tramadol and the Nurofen and all the things working, because at the moment when I have my flare-ups, they go for a couple of days. I was in King Eddie's for 2 months ago for like 4 days, just because I couldn't move and my blood pressure was so low. It was horrible. So I'm now at that point where I think I need to make an appointment with you, Sean, to come and talk about a hysterectomy, because yeah, there's a whole bunch of things, and I appreciate that hysterectomy isn't always the path forward, but something's got to give. And it's like, this is a 25-year battle, and it's consuming, and it's exhausting. I know we all feel it. Yes, I'm really just sharing. So if this is, yeah, I apologize if this is, yeah, too much or not enough. You're not alone. I think I touched on that just beforehand, but finding your people is probably the biggest and most important thing.
if you don't gel with a doctor, they're not the doctor for you. I think there's nothing more scary than going into these meetings or going into these appointments and these surgeries and not knowing how you're going to navigate through it and not feeling like someone's on your team. And I think you 100% have to advocate for yourself. You know your body better than anyone else. But at the same time, your doctors should be the people who give you confidence that this is something worthwhile trying. I absolutely adore my specialist. He is based in Sydney. I'm from Sydney originally. I moved here 5 years ago. I at one point was like, could you be my GP as well? He's like, I don't specialize in that because I just loved having him in my life. He also delivered my first baby. But I think there is, yeah, just we're really fortunate, I think, in Australia to have a lot of incredible doctors who do specialize in this. And while GPs, I hope, getting much better at this, you know, we've seen examples today of the pelvic clinic as well, and different places where you can find information. And yeah, I would really encourage you to seek that out, and also to find your community. And I think the Endo WA Facebook group is just such a brilliant place where there are people who come together and share all experiences. I'm assuming that's how most of you found out about today. There's something about being seen, and there's also something about having the confidence to speak your truth and to speak up. And I think when you find people, peers who are on that walk or in that same stage of life, they give you the confidence to know that it's not normal and that you deserve to be listened to, because you do. Medical misogyny, I'm really passionate about this. I think we exist in a system that is not designed around women and their needs. And a lot of energy and effort is being invested in that. And I do think it's really, I'm not going to get political. I know we're on the cusp of federal election and I work in that space, so I need to not go down that path because I get really passionate about it, but really hopeful. Both sides of the political spectrum at the moment have spoken quite openly about endometriosis as a priority for them, which is really cool to see, because there aren't a lot of shared, I think, passions on both sides. But endometriosis is something that is getting increased attention. And I think the more, you know, we advocate for ourselves, but also advocate for the community and do speak up in our workplaces, in our schools, in our homes, in our community about this topic, the more attention and the more energy it's going to get. And these issues that we're all facing will hopefully become a thing of the past. But we do need to feel like we can, I guess, address some of those issues that we exist in a system that wasn't initially built for women. And a lot of the diagnostic tools, while they're getting better now, you know, were built on male physiology. And yeah, that obviously compounds. Be kind to yourself. I know I've said this a bit as well, but it's a never-ending walk and it's really hard. I've been doing this for 25 years and my walk is nowhere near over, even though I've had different seasons where it's been a whole lot more manageable compared to seasons where it's not. I think no matter, if this is your walk, it's your walk. And so you kind of have to, unfortunately, take a step back and accept it. You can have surgeries, you can try the diets, you can try the pelvic floor work and stuff, which does 1,000 times help. But the reality is you will likely have endometriosis probably for the rest of your life, as much as that's horrible. And I think having that mindset gives you a little bit more control over it, because it's not something that we can just flick a switch and it goes away. So I think it's okay to put yourself first when you need to, and I encourage you to do that. I think often we don't. It's okay to speak up. It's okay to say, this doesn't work for me today. It's okay to tell people in the office that you have a period and it really sucks. And that's part of your journey, because that is part of your journey. And if people feel uncomfortable with that, well, then that's their problem. Maybe I'm being a bit too aggressive on that front, but I do think we need to normalize this stuff. This is 1 in 7 women and people who are assigned female at birth. It's 120,000 West Australians who have endometriosis, most likely plus. So when you think about it in that context, you're not alone. And the more we progress together, the more it will change for future generations. And the more we won't feel alone when we go in and have these conversations. And the more when we walk in, people will go, yeah, okay, I know the walk you're walking and I want to be here to support you. So yeah, I guess you're not alone. Thank you for giving me time to talk through my journey. But yeah, I see you and I hear you, and please try and create space for yourself, because it sucks, but you're not alone. Thank you.
I'm so sorry. It's just the ICU and ICU gets me every time. Hormones, endo. It's just everyone's journey is so different, but there are so many common elements that I hear that resonate in everyone's stories, and it just
Yeah.
it pulls the right heartstrings.
Thanks. I was a bit nervous.
So thank you so
That's
much
okay.
for sharing with us
That's
today.
okay.
Thank you.
Oh, yeah. Sure. All the time. All the time. Yeah. All the time. Oh, geez, that's a question. How do I deal with imposter syndrome? Be vulnerable about it. I think I was really lucky to work with someone who a couple of years ago, when she was starting the job, it was a big job. She kind of said, I'm freaking out. I've got massive imposter syndrome. I don't think I'm the right person to be doing this, but I'm here and I'm going to give it a go. And it set the tone for the rest of us to be like, okay, well, we're all freaking out and this is a lot of work. And so my work specifically at Minderoo, which is a philanthropic organisation, we invest in gender equality. Unfortunately, not health, but I'm fighting a good fight and trying to get that on the radar. But, you know, it's a lot of responsibility to be standing essentially at the checkbook writing, how do we define how women and girls are uplifted in Australian society over the next 20, 30 years? And being vulnerable about the fact that we are who we are and we have our own experiences, I think changes the imposter syndrome. And also your experience is valid. It might be slightly different to someone else's, but it's valid. And you go through all the different things. And at the end of the day, what defines an experience? It's your walk, like it's your personal story. And just because it doesn't look like somebody else's, you don't know what theirs is, they don't know what yours is. And I think that's part of that being kind to yourself. You have to create space and go, actually, no, this is something real. This isn't me just being in my head. This is me and my life. And my life counts. And my day-to-day counts. And the feelings I'm feeling, they're valid. And that's, I guess, maybe a self-acceptance thing, first and foremost, from an imposter syndrome. But if you find out how to manage it completely, please let me know, because I have not conquered that yet.
I think all of us are still working through how to manage imposter syndrome.
So thank you. I'm sticking around if anyone wants to chat afterwards as well.
Thank you, Clem. Thank you. Very, very brave. Okay, so before I wind this up, I would just like to thank today's sponsor, Proteomics International, for helping organise all the speakers, get the venue, the food, everything. Like, you've been amazing, Catherine. Thank you so much. I would also like to thank Bianca Cooper at Endometriosis Western Australia for all of her efforts in coordinating with Catherine today's event and speakers. It's been a wild ride. It's been a lot of information, and I'm looking forward to chatting with everyone for tea and coffee. And some snacks after this as well. Thank you all for attending. We've got networking in the lobby until 1 o'clock. Feel free to stay and chat and ask anyone any questions you would like. Thank you for joining us today.